Let me be completely honest with you right now. What I am about to tell you today could very well save your life, or the life of someone you love deeply. And I want you to stay with me through every single word of this, because this is not the kind of conversation most doctors have openly. This is the kind of conversation that usually happens in hushed hallways, between colleagues, away from the patient, away from the family. But I am done with that. I have spent over 2 decades as a cardiothoracic surgeon. I have stood at operating tables for more hours than I care to count. I have held a beating human heart in my gloved hands. I have watched families in waiting rooms, hopeful, terrified, trusting, and I have had to walk out and tell them that things did not go the way we planned. And after all of those years, after all of those operations, after all of those moments, I have arrived at a truth that I believe every person over the age of 60 absolutely must hear. Sometimes, and I want you to absorb this carefully, sometimes the surgery itself is more dangerous than the disease. That statement will probably shock some of you. You may be sitting there thinking, but doctor, if a surgeon recommends an operation, surely that must be the safest path forward. I understand that instinct completely. We have been raised in a culture that trusts the white coat, that treats a surgical recommendation almost like a divine verdict, something handed down that you simply accept without question. The surgeon says you need this operation, and so you sign the consent form, and you kiss your family goodbye at the pre-op ward, and you trust that modern medicine will bring you back to them whole. I understand that trust. I am humbled by that trust every single day, but trust without information is not safety. Trust without understanding is not wisdom. And today, my job is to give you the information that transforms your trust into something far more powerful: informed, active, empowered participation in your own healthcare. Because here is what nobody tells you clearly enough. When a patient is young, fit, and healthy, the human body has an extraordinary capacity to recover from surgical trauma. A 35-year-old who undergoes a major abdominal procedure will typically bounce back with remarkable speed. The heart is strong, the lungs are resilient, the immune system is aggressive and efficient, the muscles rebuild quickly, the mind stays sharp through the fog of anesthesia and post-operative pain medications. The body at 35 has enormous reserve. Think of it like a financial account. A young person walks into a major surgery with millions in that account. The surgery makes a significant withdrawal. It is painful, it is stressful, it is traumatic to the body, but there are still plenty of reserves left to fund the recovery. Now think about what happens when that same withdrawal is made from an account that only has a few $100s left in it. That is what we are dealing with in many of our elderly patients, and I say that not to be grim, but to be honest. Because age itself is not the enemy here. I need you to understand that distinction very clearly. I have operated on 82-year-olds who sailed through complex procedures with the resilience of someone 20 years younger. I have also seen 58-year-olds who were so depleted, so frail, so burdened by multiple chronic conditions that even a relatively minor procedure triggered a catastrophic cascade. The number on your birth certificate does not determine your surgical risk. What determines it is something we call biological reserve, the true functional capacity of your heart, your lungs, your kidneys, your muscles, your brain, and your immune system taken together as a whole. And this is where I introduce you to a word that every person over 60 needs to learn, to understand, and to ask about when they are sitting across from any surgeon. That word is frailty. Now, in medicine, frailty does not mean what it means in everyday conversation. It is not simply about being thin or moving slowly or needing a cane. Frailty is a precise clinical concept. It refers to a state of decreased physiological reserve and resistance to stressors. A frail patient may look perfectly fine sitting in a clinic chair. They may be cognitively sharp, they may be well-dressed and well-spoken and deeply engaged, but when you put them through the extraordinary physical stress of a major surgical procedure, the anesthesia, the blood loss, the inflammation, the immobility, the narcotic pain medications, the disruption of sleep and nutrition, their system simply cannot absorb and recover from that level of assault. The reserve is not there. and the consequences can be devastating and permanent. Studies have shown again and again that frailty is one of the most powerful predictors of post-surgical complications, prolonged hospital stays, admission to nursing facilities, and mortality in older patients. And yet, and this is what troubles me deeply, frailty screening is not a routine part of every surgical consultation in the way that it should be. Patients are assessed for their cardiac function, their respiratory function, their blood counts. But far too often, the broader, holistic question of whether this person's entire system can handle what we are about to put it through does not receive the careful, systematic attention it deserves. That is a gap that can cost lives. And you, sitting here today, are now equipped with the knowledge to close that gap yourself by asking the right questions, which I will give you before this speech is over. But first, let us talk about the 5 surgeries that I have seen carry the most serious and often underappreciated risks for older adults. I am not telling you that these procedures are never appropriate. I am not telling you to refuse them categorically. What I am telling you is that for seniors, particularly those with frailty, multiple chronic conditions, or limited reserve, these are the operations that demand the most careful scrutiny, the most honest conversation, and the most thorough exploration of alternatives before a decision is made. The first one I want to talk about is open heart surgery in the elderly frail patient. Now, I am a cardiothoracic surgeon. The heart is my domain. And I can tell you with deep personal authority that open heart surgery, particularly procedures like open aortic valve replacement or complex coronary artery bypass grafting, is one of the most physiologically demanding experiences a human body can endure. We stop the heart. We put the patient on a bypass machine that takes over the work of the heart and lungs artificially. We perform meticulous repairs in a bloodless field, and then we restart the heart and bring the patient off bypass. When this is done in a robust patient with good reserve, the outcomes are often excellent and genuinely life-changing. But in a frail elderly patient, the story can be tragically different. The bypass machine itself triggers a systemic inflammatory response that can be devastating to the older body. Cognitive complications, what patients and families sometimes call pump head, can cause confusion, memory problems, and personality changes that persist for months or sometimes permanently. In frail patients, the risk of prolonged ventilation, kidney failure, wound infection, and inability to return to independent living is substantially elevated. And this is why I want every senior with significant aortic valve disease, every senior being recommended for complex cardiac surgery, to ask their cardiologist and their surgeon point blank, am I a candidate for a minimally invasive alternative? Because in many cases, the answer is yes. Transcatheter aortic valve implantation, which we call TAVI or TAVR, has been a genuinely revolutionary development in cardiac care. Instead of cracking open the chest, stopping the heart, and operating on bypass, we can often deliver a new valve through a catheter, a thin, flexible tube, inserted through the groin or chest wall with a much smaller physiological footprint. For the right patient, TAVI offers comparable or superior outcomes with dramatically reduced recovery time and complication rates. If you or someone you love is facing open heart surgery and is over 60, the question, am I a TAVI candidate, may be the most important question you ever ask. Now, let us move to the second surgery on this list, and this one affects millions of people every single year: aggressive spinal surgery for chronic back pain. I cannot tell you how many patients I have encountered, not my primary cases, but people in my orbit referred through colleagues brought to me for second opinions, who agreed to major spinal procedures for degenerative back disease and came out the other side in more pain, with less function, and with a quality of life that had declined rather than improved. Back pain in older adults is extraordinarily common. The spine degenerates with age, discs shrink and dry out, vertebrae develop bone spurs, joints stiffen and inflame. And when a senior is suffering with chronic back pain, when they have been through months or years of conservative management and they are desperate, the idea of a surgical solution can feel like a lifeline, A surgeon shows them an MRI with impressive-looking pathology, bulging discs, narrowing of the spinal canal, degenerative changes at multiple levels, and says, "This is why you hurt, and we can fix it." But here is what the research tells us, and it tells us this with uncomfortable consistency. For many types of chronic back pain in older adults, major spinal surgery, multilevel fusions, complex decompressions, does not reliably produce better outcomes than well-managed non-surgical care. And in frail elderly patients, the risks are severe. General anesthesia for prolonged spinal procedures carries significant risks. Blood loss can be substantial. The post-operative period requires physical rehabilitation that a frail patient may struggle enormously to complete. Instrumented spinal fusions involve placing hardware, rods, screws, cages, into bone that in an elderly osteoporotic patient may not hold that hardware reliably, leading to implant failure and the need for further procedures. And perhaps most sobering of all, there is a real phenomenon where a patient has surgery at one level of the spine only to develop accelerated degeneration and pain at the levels immediately above and below the fusion within a few years. I am not saying spinal surgery is never the right answer. For specific, well-defined problems, a genuine acute disc herniation compressing a nerve root, significant spinal stenosis causing progressive neurological deficit, surgery can be truly transformative. But for diffuse, multi-level chronic degenerative back pain in an elderly patient, I urge tremendous caution and a very honest conversation about realistic expectations. The third surgery I want you to know about is major cancer resection in advanced age, and specifically, I want to address what is sometimes called futile surgery. When someone receives a cancer diagnosis, there is a powerful, completely understandable human drive to do something, to act, to fight, to cut out the disease and be done with it. Oncological surgery has saved countless lives, and I would never minimize that. But there are situations, particularly with certain complex cancers in elderly patients, where major resective surgery carries extraordinary risk and offers minimal realistic survival benefit. The procedure I think about most in this context is the Whipple procedure, a pancreaticoduodenectomy, which is the surgical treatment for cancer of the head of the pancreas and certain other cancers of the upper gastrointestinal tract. It is one of the most complex operations in all of surgery. The surgeon removes the head of the pancreas, the duodenum, part of the bile duct, the gallbladder, and sometimes part of the stomach, and then reconstructs the entire digestive anatomy with multiple surgical connections. In experienced hands at high-volume centers, outcomes have improved dramatically over the past several decades. But this is still a procedure with significant morbidity and mortality rates, particularly in frail elderly patients. The recovery is prolonged, painful, and demanding. Complications including leakage from the surgical connections, infections, delayed gastric emptying, and diabetes are common. And the difficult truth, the truth that oncological surgeons and palliative care specialists discuss candidly among themselves, is that in some elderly frail patients with cancer, an aggressive major resection offers a very marginal extension of life at the cost of the quality of whatever time remains, while excellent palliative care and targeted therapies could provide far greater comfort, function, and meaningful time with loved ones. These are not easy conversations. They are among the most difficult in all of medicine. But they are conversations that deserve to happen, openly and honestly, with full information on the table, before a surgical decision is made. The fourth surgery I want to address is elective joint replacement, hip replacement, knee replacement, in patients who are severely medically compromised. Now, please hear me carefully here, because joint replacement surgery has genuinely transformed the lives of millions of older adults. A well-timed, well-executed hip or knee replacement in an appropriate patient can take someone from debilitating pain and immobility to walking, gardening, traveling, and living fully within weeks. These are wonderful operations with wonderful outcomes when performed in the right patient. But the word in that sentence that carries all the weight is appropriate. When a patient has severe, poorly controlled heart disease, significant respiratory compromise, advanced kidney disease, poorly managed diabetes, or profound frailty, the risk profile of even a routine joint replacement changes dramatically. The anesthesia, the blood loss, the risk of deep vein thrombosis and pulmonary embolism, the demands of post-operative physical therapy, the stress on already compromised organ systems, these risks escalate steeply in the presence of significant underlying illness. I have seen patients in their 70s and 80s with multiple serious comorbidities, that is the medical word for additional diseases occurring alongside the primary condition, undergo elective knee replacements and spend months in rehabilitation hospitals, never return to independent living, and lose the very quality of life the surgery was meant to restore. The timing and sequencing of elective procedures matters enormously. If your knee is painful and your heart condition is poorly controlled, the appropriate path may be to aggressively optimize your heart condition first, then revisit the knee replacement decision from a place of better health. If your diabetes is poorly managed, getting your blood sugar under control before surgery significantly reduces your risk of wound infection and impaired healing. Elective surgery is, by definition, a choice. It should always be a well-timed choice made from the strongest possible position. The fifth and final surgery I want to speak to is emergency abdominal surgery, and this one is different from the others because it is not usually truly elective. When someone develops a perforated bowel, a ruptured abdominal aneurysm, a severe abdominal infection requiring immediate surgical intervention, you cannot always say, "Let us wait and optimize." The surgery may be acutely necessary to preserve life. But the reason this is on this list is not to tell you to refuse emergency surgery. It is to tell you that the best defense against the catastrophic risks of emergency abdominal surgery in elderly patients is early detection and timely intervention before the emergency occurs. A leaking aortic aneurysm that reaches the operating room before it ruptures carries a mortality rate that is a fraction of the same aneurysm managed as a true rupture. Bowel obstruction managed early and aggressively carries far better outcomes than bowel obstruction left until the tissue has died and perforation has occurred. Diverticular disease caught and managed appropriately before it leads to a perforation requiring emergency resection, and colostomy can spare an elderly patient an extraordinarily difficult surgical experience. This is why I am passionate about the importance of regular monitoring, regular imaging in high-risk patients, and regular honest conversations with your physician about your risk for the conditions that can lead to abdominal surgical emergencies. Abdominal aortic aneurysms can be screened for with a simple ultrasound. Men over 65 who have ever smoked should have this screening. Knowing that an aneurysm exists, monitoring it, and planning a careful elective repair when it reaches a threshold size is infinitely preferable to the devastating alternative. Prevention and early detection are not passive choices. They are the most powerful surgical interventions available to you. Now I want to give you something concrete and actionable, because information without action is just anxiety. Before any major surgery, before you sign any consent form, before you schedule any preoperative testing, I want you to ask your surgeon 4 questions. Write these down, put them in your phone. Share them with your family members who may accompany you to medical appointments, because sometimes we are overwhelmed in the moment and we forget what we meant to ask. The first question is, what is my frailty status and how does it affect my surgical risk? You are asking the surgeon to look at you not just as a cardiac patient or a spine patient or an oncology patient, but as a whole person with an overall biological reserve that either supports or limits safe surgical recovery. If the surgeon cannot answer this question or seems unfamiliar with frailty assessment tools, that is important information in itself. The second question is, what are the realistic alternatives to surgery, and what happens if I choose not to operate? Sometimes the most dangerous thing a surgeon can tell you is that surgery is your only option and you have no choice. In most situations, there are alternatives: medical management, minimally invasive procedures, watchful waiting with careful monitoring, palliative and comfort-focused care. You deserve to understand all of them. The decision not to operate is a legitimate, valid medical choice, and it should always be on the table. The third question is, what does success actually look like for me, specifically with my health profile and my goals? This is not asking for the average outcome. This is asking the surgeon to look at you, your age, your comorbidities, your frailty, your personal priorities, and give you an honest, individualized projection. Success for a robust 65-year-old may mean full return to independent active living. Success for a frail 80-year-old may mean something far more modest, and you need to know that before you decide whether the surgery is worth the risk and recovery. The fourth question is, what can I do before surgery to improve my outcomes? And this brings me to one of the most exciting and underutilized concepts in modern surgical care, a concept called prehabilitation. We talk constantly about rehabilitation, the work you do after surgery to recover your function. But prehabilitation is the deliberate, structured effort to build up your physical reserve, your nutrition, your strength, and your cardiovascular fitness before you go to the operating room, so that when the surgical withdrawal is made from your account, the account has more in it. Research is increasingly robust on this point. Patients who engage in structured prehabilitation programs, even brief ones of 4 to 8 weeks, show measurably better surgical outcomes, reduced complication rates, shorter hospital stays, and faster return to independent function. Walking every day, working with a physical therapist on targeted strengthening exercises, optimizing your protein intake, quitting smoking, getting your blood sugar under better control. These are not passive preparations. They are active medical interventions that improve your chance of surviving and thriving through a major operation. And beyond prehabilitation, I want to speak briefly about the importance of knowing your wishes in advance and ensuring that your family and your medical team know them too. Advanced care planning, having a documented record of what interventions you would and would not want in various scenarios, who is designated to make decisions for you if you cannot make them yourself, is not morbid. It is not giving up. It is one of the most profound acts of love and self-determination you can engage in, because it ensures that if you are ever in a position where you cannot speak for yourself, your voice is still present in the room. I have seen too many families torn apart in surgical waiting rooms and ICUs because nobody had ever sat down and asked the patient, in a calm and unhurried setting, what they truly wanted. Do not let that be your family. Have that conversation. Document it. Make sure your physician has a copy. I want to circle back to where I began because I think it is important that you leave this conversation with the right framework in your mind. I am not here today to frighten you away from surgery. I am not here to tell you that surgeons are reckless or that the medical system does not care about its elderly patients. The vast majority of surgeons I know are deeply dedicated, thoughtful, technically brilliant professionals who genuinely want the best for every patient they care for. But the medical system operates under pressures: time pressure, resource pressure, the pressure of clear surgical pathology that seems to demand a surgical response, that can sometimes make it difficult to slow down and have the full, nuanced, individualized conversation that every elderly patient deserves. And so I am asking you to be the force that slows that conversation down. I am asking you to be the person who comes prepared with questions. I am asking you to be the advocate for yourself, for your parent, for your spouse, for your friend, who insists that before anyone picks up a scalpel, every alternative has been genuinely considered, every risk has been honestly disclosed, and every goal has been clearly understood. A surgical recommendation is not a verdict. It is not a command. It is the beginning of a conversation, and you have every right and every responsibility to participate fully in that conversation. You are not a passive recipient of care. You are an active partner in one of the most consequential decisions of your life. The surgeon brings the technical expertise. You bring the irreplaceable knowledge of what your life means to you, what you value, what you fear, what you hope for, and what you are willing to endure in pursuit of those hopes. Both of those things have to be present in the room for a truly good decision to be made. I have seen what happens when that partnership works. When a patient comes in informed, asks the right questions, and together with their surgeon arrives at a plan that is truly right for them. I have seen 80-year-olds thrive through carefully planned operations because they took the time to prepare their bodies through prehabilitation. I have seen seniors avoid devastating complications by asking about minimally invasive alternatives that turned out to be perfectly suited to their condition. I have seen families navigate difficult cancer diagnoses with grace and clarity because they had an honest conversation about what surgery could and could not offer, and chose a path that preserved quality of life while still fighting the disease with everything available. These outcomes are possible. They are not rare. They happen when patients are equipped with knowledge and when they use it. And they happen when people like you, people who take time out of their day to seek out information, to listen, to learn, to think critically about their health, bring that knowledge into the clinic and into the consultation room and refuse to leave until they have the full picture. That is the kind of patient that changes outcomes. That is the kind of patient that every good physician is grateful for. That is the kind of patient I want every person watching this to be. So as you move forward from today, whether you are approaching a surgical consultation yourself, or whether you are helping an aging parent navigate a complex medical decision, or whether you are simply a person who believes that knowledge is the most powerful medicine available, carry this with you. Ask about frailty. Ask about alternatives. Ask about realistic goals. Ask about prehabilitation. Know your wishes and document them. And never let anyone tell you that a surgical recommendation is the end of the conversation, because it is only ever the beginning. I have given you the information today that I wish every one of my patients had walked into their first surgical consultation already knowing. I have shared with you what I have learned in over 2 decades of standing at operating tables, of seeing what works and what doesn't, of being honest with myself about the limits of what surgery can offer and the profound importance of patient empowerment in determining outcomes. If even one person watches this and asks one more question before agreeing to a procedure that may not have been right for them, then every moment of this conversation has been worth it. Now, if this conversation has been valuable to you, and I genuinely hope it has, I have a small but important request. Please subscribe to this channel if you have not done so already. Hit that subscribe button right now and make sure you ring the notification bell, because the information I share here is designed for people who take their health seriously, and I want to make sure you never miss it. Every week I bring you evidence-based, clinically grounded conversations about the things that matter most for longevity, surgical safety, and informed healthcare decision-making. This is a community of people who believe that knowledge is the foundation of health, and I want you to be a permanent part of it. And please, leave a comment below. Tell me, have you or a loved one ever faced one of these difficult surgical decisions? Did you ask the hard questions? Did you explore the alternatives? Did you feel empowered in that consultation room, or did you feel rushed and overwhelmed? I read every comment. Your experiences are not just stories. They are lessons that help this entire community, and they remind me every day why I do what I do. Drop your thoughts, your questions, your stories below.